We're starting to learn those features that really drive a worse outcome. And whether we talk about this in the context of the Mantle Cell International Prognostic Index, or the MIPI, or whether we talk about this genomically, the two overlap. So when you look at those patients who are high risk, they very commonly also are more proliferative. They very commonly also carry these p53 mutations. And so this was very nicely described by the MCL35 score, which I didn't present in tonight's talk, but basically this gene expression profiling, which tries to really capture more proliferative versus less proliferative mantle cell lymphomas, and then overlapping that with the MIPI and what's called the MIPI-C, which includes a measure of Ki67 and the p53 mutation status. Very beautiful work being done by our European colleagues, but it's highlighting this intersection of the clinical presentation and the biological behavior. As we step back and think about those patients who are at the far right, the more proliferative mantle cell lymphomas, the ones who carry these p53 mutations, the way that Martin Drayling and others would actually describe this is as a distinct subtype of mantle cell lymphoma. And in fact, when they started looking at their outcomes on the MCL2 and MCL3 trials, their high-dose induction followed by stem cell transplant studies, what they very clearly saw was these patients, in spite of being younger, did much, much worse. And so that's the first thing that I think I really need to drive home, is that high-dose chemotherapy, stem cell transplant-based approaches are not applicable for this subset of mantle cell